Hello friends, let us now learn some important points about the lesions of cerebellopontine angle. So these lesions of cerebellopontine angle includes first acoustic neuroma. Acoustic neuroma is most commonly seen in 80% of patients. Meningioma is seen in 10% of patients, whereas congenital cholesteatoma is seen in 5% of patients. Now we have vestibular schwannoma. Or acoustic neuroma. Vestibular schwannoma or acoustic neuroma. These are actually the most common intracranial schwannomas. Vestibular schwannoma or acoustic neuroma are the most common intracranial schwannoma. Here, about 80% of all cerebellopontine angle tumors are vestibular schwannomas. It is most common benign tumor of the cerebellopontine angle. Around 10% of brain tumors are vestibuloschwannomas. These vestibular schwannomas are benign, encapsulated and extremely slow growing tumors. They are benign, encapsulated, extremely slow growing tumors which are locally invasive. Most commonly inferior vestibular nerve, more commonly seen than superior vestibular nerve, most commonly seen than the cochlear nuclei. So first most common site is inferior vestibular nerve. Then we have bilateral vestibular schwannoma is actually diagnostic of neurofibromatosis too. Bilateral vestibular schwannoma is diagnosis of neurofibromatosis too. This vestibular schwannoma mainly originates in the schwann cells of inferior or superior vestibular nerve at the transition zone of central and peripheral myelin. It originates from the schwann cells at either schwann cells of superior and inferior vestibular nerves. It originates from there, and this zone is called as Oberstein-Redlich zone. That is, the zone between central and peripheral myelin is called as Oberstein-Redlich zone, and this will lie in the internal auditory canal. Then we have growth of the tumor. The tumor growth arises from the vestibular nerve, and this tumor will reach the cerebellopontine angle. It arises from the vestibular nerve and it reaches the cerebellopontine angle, and then it erodes the internal auditory meatus. Once it erodes the internal auditory meatus, it will anterosuperiorly involves the fifth cranial nerve. Anterosuperiorly it involves the fifth cranial nerve, which is the earliest nerve to be involved, and if you see inferiorly, it involves the 9th, 10th and 11th cranial nerves. Inferiorly it involves the 9th, 10th and 11th cranial nerves, which lies in jugular foramen. Then if you see the disease acoustic neuroma will displace the brainstem, and this acoustic neuroma will put pressure on the cerebellum. It displaces the brainstem and puts pressure on the cerebellum, thus increasing the intracranial tension. Almost 70% of acoustic neuromas will grow slowly over years. They will grow slowly over years, and almost 30% are stable. So if you see the clinical features, vestibular schwannoma or acoustic neuroma, these are most commonly seen in the age group of 40 to 60 years. If they are seen in 20 to 30 years, always think that it is associated with neurofibromatosis too. It is seen in both equally in males and females. This acoustic neuroma or vestibular schwannoma is a radio-resistant tumor, and 90% of the cases it is seen unilaterally, but bilaterally it is seen in von Recklinghausen's disease or in neurofibromatosis. You will see bilateral vestibular schwannomas. Now, if you see the symptoms, the earliest symptom of vestibular schwannoma is cochleovestibular symptoms. Earliest symptom is cochleovestibular symptoms, where you will see presence of deafness, tinnitus, and you will most commonly see progressive unilateral sensory neural hearing loss is seen in 95% of the cases, and tinnitus is seen in 65% of the cases. And sometimes you will also see presence of true vertigo is also seen. Then if you see the involvement of, you will see involvement of facial nerve. In this, the sensory fibers are more sensitive, whereas the motor fibers are more resistant. In facial nerve, sensory fibers are more sensitive to vestibular schwannoma, motor fibers are more resistant. Histopathology sign can occur whenever this vestibular schwannoma involves the facial nerve. This will cause numbness over the posterior aspect of concha, and this is called as Histopathology sign. Then we can do Electro Gustometry. In Electro Gustometry, you will see that there is loss of taste sensation seen in the anterior two-thirds of the tongue, and Skirmer test will show decreased lacrimation, and we can see blink reflex. Blink reflex is also delayed. Then one more important thing is involvement of fifth nerve. Involvement of fifth nerve. Here tumor, if the tumor in cerebellopontine angle is approximately equal to 2.5 centimeter size, then fifth nerve is involved. It will decrease the corneal sensitivity is seen, which is the earliest sign. Numbness of or paresthesia of face is also seen. Then the next involvement, there is involvement of 9th and 10th nerve, where you see presence of dysphagia, hoarseness of voice, nasal regurgitation is seen, or there can be palatal, pharyngeal and laryngeal paralysis is seen. There is pharyngeal and laryngeal paralysis is seen due to involvement of 9th and 10th cranial nerves. There is also involvement of 11th, 12th, 3rd and 4th and 6th cranial nerves when the tumor is very large. Then sometimes it can also involve the brainstem, where if it involves the brainstem, you will see that there is weakness and numbness of arms and legs is seen. If you see, there is weakness and numbness of arms and legs is seen with increased tendon reflexes. So these are the important things in important involvement in vestibular schwannoma or acoustic neuroma. Then involvement of cerebellum. If there is involvement of cerebellum, there is finger nose test, knee heel test can be done, and dysdiadokinesia can be done. We can do ataxic gait can occur, or inability to walk in a straight line. So if there is involvement of cerebellum, we have to do finger nose test, knee heel test. Both these show some incoordination. Dysdiadokinesia is seen, ataxic gait is seen, and the patient is unable to walk in a straight line. Then whenever there is involvement of brain, it causes increase in intracranial tension, which causes blurring of vision, headache, nausea, vomiting and diplopia is seen. And if there is involvement of fundus, it can cause papilledema. Then in terminal stages, you can see that it causes herniation of cerebellar tonsils occurs, and there is also failure of vital centers in brainstem occurs in terminal stages. So these are the main important points in spread of acoustic neuroma. Now if you see the histopathology of acoustic neuroma, in histopathology you will see presence of two patterns. One, we have Antony A pattern, and second we have Antony B pattern. In Antony A pattern, you will see that the cells are closely packed cells with small spindle shaped and darkly stained nuclei. These cells are closely packed cells with small spindle shaped and darkly stained nuclei. These are Verroco bodies. Then we have Antony B pattern, where you see that the cells are loosely aggregated. There is loose cellular aggregation of vacuolated pleomorphic cells are seen. That is Antony B pattern. This is Antony A pattern, where you see that the cells are closely packed with small spindle shaped. Here they are loosely aggregated in Antony B pattern. It's not clearly visible, right? I'll show you the pictures at the end. Now, if you see the classification, in the classification, if it is based on the size, we can classify it into 5 grades. So, grade 1 intrameatal tumor is, the size is small, that is 1 to 10 millimeters. Then grade 2 is medium sized, that is 11 to 20 millimeters. Grade 3 is moderately large sized, that is 21 to 30 millimeters. Grade 4 is large sized tumor, 31 to 40 millimeters. Grade 5 is giant tumor, which is more than 40 millimeters. Now, if you see the investigations, audiological test shows retrocochlear hearing loss. This audiological test shows Rin is positive, Weber's is seen towards the normal size, Squabach is shortened. And if you do pure tone audiometry, it shows sensory neural hearing loss, tone decay is more than 30 decibels, recruitment is negative. And if you do a speech discrimination score, you will see that the speech discrimination score is poor. If you do brainstem evoked response audiometry, you will see a delay of more than 0.2 milliseconds in wave 5 between the two sides. And this is actually the best test for acoustic neuroma. Then we have to see acoustic reflex. Acoustic reflex is actually stapedial reflex delay. Then we have vestibular test, which is also called as caloric test. This vestibular or caloric test shows decreased or absent response. It shows decreased or absent response. This vestibular test may be normal if the tumor is small. Vestibular test may be normal if the tumor is small. Then this vestibular test is normal if tumor is small, and caloric test is mainly for lateral semicircular canal. So caloric test will show decreased or absent response. Then investigation of choice is gadolinium enhanced MRI is done, which shows 100% diagnosis. Then if you see the treatment, surgery is the treatment of choice. Then surgical approach is also important. Surgery is the treatment of choice. Then surgical approach is important. So in the surgical approach and indication, so first, if we can do hearing preservation, in cases of hearing preservation, we do rectosigmoidal approach. Here this is indicated for patients with good hearing and when the tumor is large, that is more than 3 centimeters. Now, second, we can do middle cranial fossa approach if the patient has good hearing and the tumor size is less than 1.5 centimeters. Tumor size is less than 1.5 centimeters. With middle cranial fossa approach, we can do this approach. Then retrolabyrinthine approach can be done for small cerebello for small cerebellopedunculaar angle tumors. Retrolabyrinthine approach is done for small cerebellopedunculaar tumor which is not extending into the lateral part of internal auditory canal. Then we have to do hearing ablation can be done. Hearing ablation, this hearing ablation so here this is done by translabyrinthine approach. In translabyrinthine approach, if the tumor size is less than 3 centimeters, this approach is done. But the main disadvantage is here we are making the patient lose the ear because of sensory neural hearing loss will occur after the surgery. Then hearing rehabilitation after tumor excision. After the tumor excision, we will have to maintain hearing of the patient by doing either the cochlear implant or we can do auditory brainstem implant. Auditory brainstem implant is done if there is bilateral acoustic neuroma. In bilateral acoustic neuroma, we do this auditory brainstem implant, or else we will do cochlear implant. Then we have stereotactic surgery or gamma knife surgery. In this stereotactic or gamma knife surgery, radiation is delivered with cobalt-60, and this stereotactic surgery concentrates high dose of radiation on the tumor. So, growth is arrested without surrounding tissue. This will concentrate high dose of radiation on the tumor. So, growth is arrested without surrounding tissues. So, this stereotactic surgery is used in patients who refuse surgery. The source of radiation is around cobalt-60 is the source of radiation. Advantages of stereotactic surgery or gamma knife surgery include no morbidity occurs due to surgery, seventh nerve function is preserved, hearing is preserved, and you will also see that there is modification of gamma knife is seen is equal to X knife. Now, source of radiation is linear accelerator. Source of radiation here is linear accelerator. Cyber knife can also be used. This cyber knife is a type of robotic surgery. This surgery is done by computer controlled robotics. So, this is about the acoustic neuroma. Thank you for watching.